Hi everyone. Thank you for attending our annual BUU Urology update. I'm Dr. Chan, and today I've been tasked by the organizers to give a very important topic titled Doctor, I have blood in my urine. Blood in the urine is also known as hematuria. And hematuria is a very common presentation in urology. What is most important about hematuria is that we have to rule out malignancy until proven otherwise, because a lot of urological malignancies present with hematuria. Hematuria basically signifies that bleeding is occurring somewhere in the urinary tract, and this can be anywhere from the glomerula in the kidney right up to the urethral meatus. So the number of causes for hematuria is numerous, and because the pathology is so numerous, we need to be organized in how we evaluate the patients with hematuria. And the causes of hematuria may range from benign causes such as stones and infection, ranging to important conditions such as pregnancy. So what do we consider when a patient comes to us to the clinic and walk in presenting with blood in the urine? When we take a history, these are the things that we need to consider. First, age of the patient. The older the patient, the higher the chances the patient may have malignancy. Whether the hematuria is microscopic or macroscopic, meaning whether they could see the blood in the urine or not. In other words, whether it's visible or non-visible. Visible hematuria usually signifies a significant pathology, whereas non-visible hematuria may not be so urgent. Whether there's painful or painless hematuria. When a patient presenting with abdominal pain, classic loin to groin pain with hematuria, then we usually need to evaluate for urinary stone disease. Whether a patient has lower urinary tract symptoms. Presence of urinary tract symptoms basically means the pathology, we could isolate the pathology to the urinary tract in the presence of these symptoms, and whether there are risk factors for urinary tract malignancies. So first we go into age. Let's say a pediatric patient coming with hematuria, then we can be rest assured that malignancy is unlikely in this age group. Most common conditions in this age group are glomerular disease, so we need to evaluate for such conditions. Similarly, in a young adult, urinary stones are usually the most common presentation. However, in an older adult with hematuria, then we need to make sure there's no urinary tract malignancies. As you can see from this graph, bladder cancer is really rare in those who are less than 40 years old. So it will not be in patients who are above 40 years old, then we need to actively look out for bladder cancer. As mentioned earlier, we need to find out in history whether the patient has visible hematuria or non-visible hematuria. In the presence of visible hematuria, then a significant pathology is more usual. As mentioned earlier, up to 60% of patients with non-visible hematuria may not have a significant pathology. In the presence of gross hematuria, we can also find out whether the blood is found throughout the stream of the urine or only just in the initial or at the end of urination. If blood is found throughout the stream of the urine, then the pathology or the condition is slightly above the bladder neck. This is because there's time for the blood to mix with the urine, and therefore the source of the bleeding is likely to be above the level of the bladder neck, as opposed to if you can see the bleeding only at the initial bit or a dripping of urine at the end of urination, then pathology is likely to be below the bladder neck, i.e. the prostate or the urethra or the meatus. So microscopic hematuria, non-visible hematuria is really common. That is, we frequently get referred by the general practitioners when the patient incidentally was found to have microscopic hematuria. It is defined as 3 to 5 red blood cells per high power field or 8 RBC per microliter. Sometimes it's found, microscopic hematuria is found through dipstick examination. But dipstick examination alone does not signify microscopic hematuria. It needs to be confirmed with microscopy. This is because there are few conditions that can cause false dipstick examination, such as microglobinuria and oxidizing agents such as vitamin C or patients with severe dehydration. So microscopic hematuria, as mentioned earlier, often does not have significant pathology, especially in the young adults. In a study that followed 1,000 young adults for 15 years, the incidence of urological malignancy in this population is really small, only 0.1%, and almost the same as the general population. So we do not really need to actively look for urological malignancy in a young adult with microscopic imaging. However, it has been found that in this same group of patients, there's significant incidence of chronic kidney disease. There's a higher incidence of end-stage renal failure later in this group of patients. And therefore, if in this group of patients, it may be prudent to refer them to a nephrologist for long-term follow-up for chronic kidney disease. So in this landmark study by Murakami, an important study that investigated 1,000 patients with asymptomatic microscopic hematuria, there was a 2.3% incidence of urological malignancy, and almost all these cases are amongst those who are above 40 years old. So now, in most international guidelines, for patients with asymptomatic microscopic hematuria who's above 40 years old, they should undergo a full urological evaluation, which includes a cystoscopy. Okay, in our evaluation, we need to also make sure find out for the risk factors of urinary tract malignancies, and this includes smoking, high-risk occupation that involve dye and chemical, previous radiotherapy to the pelvis, those who have been chronically catheterized, resulting in frequent recurrent UTI, those who have a family history of renal cancer. As we know, certain renal cancers are familial in origin, and those who's taking medications who increases the risk of urinary tract malignancy, such as cyclophosphamide or certain analgesics. Glomerular disease is a frequent cause for hematuria. So we need to look for associated symptoms for glomerular disease, such as associated proteinuria, edema, hypertension, and if you can see RBC cast or dysmorphic RBCs in the microscopic examination, then we should suspect glomerular disease. In the event of glomerular disease, then the patient should be referred to a nephrologist rather than a urologist. In our evaluation, we should also look out for benign causes. There are many common benign causes for hematuria, and actually these are the most common reasons for patients presenting with hematuria, and we should make sure that these conditions are ruled out before we evaluate further. First of all, we should make sure that lady is not actively menstruating. If she has hematuria during her menstruation, then we should reevaluate again after the menstruation stop. We should also look out for active urinary tract infections. In the presence of symptoms suggestive of urinary tract infection, then the urinary tract infection should be treated first. And after it has been treated, then the patient re-evaluated again. Vigorous exercise has been known to cause hematuria. If a patient's hematuria episode occurs every time after vigorous exercise, such as a marathon or intensive gym session, and they have 1 or 2 episodes of hematuria right immediately after the session, and is perfectly well in between, then we should suspect that the exercise itself was a cause for the hematuria. Sexual activity and trauma could sometimes cause hematuria. So we go on to investigation. After a thorough history evaluation, as I mentioned earlier, then we go on to investigation. So we should divide patients into either low risk or high risk for urinary tract malignancy. Those who are low risk includes those who are younger than 40 years old, those with microscopic hematuria, and those without any risk factors for urinary tract malignancies. In this group of patients, all you need to do investigate is do a simple ultrasound KUV. This is cheap, easily available, and should be enough to investigate low risk patients. For any higher risk patients, those who are older than 40, risk factors for urinary tract malignancies or those with gross hematuria, then they should be fully evaluated with both upper tract imaging and cystoscopy. Upper tract imaging gold standard is CT-IVU. In the old days, it used to be IVU, but this has been largely replaced with CT-IVU, which means contrasted, multiphasic contrasted CT. For some patients where CT scan is contraindicated, then we may do ultrasound with X-ray KUV or MRI instead. As for lower tract imaging, then a cystoscopy should be performed. This could be done under local anesthesia as a day procedure using flexible cystoscopy. So in summary, hematuria is a common and important urological condition, and in patients with hematuria, we should always try to rule out urinary tract malignancy. With this, I thank you and happy to take any questions from the audience.